Good morning, everyone. My name is Marta Dzhus, and I represent Bohumolets National Medical University in Kyiv, Ukraine. I am honored to present our research on sarcopenia in inflammatory arthritis. This is our joint work together with Miroslava Kulik, who is PhD student, Tatiana Karasevska, who is associated professor, and Helena Muspau, who is the head of the department. This topic reflects an intersection of musculoskeletal, metabolic, and rheumatic science and reveals significant clinical implication, especially for young patients living with chronic inflammatory conditions. Here's a roadmap for today's talk. I will begin by defining sarcopenia and outlining key mechanisms of muscle loss in rheumatic diseases. We'll then explore how sarcopenia present in different forms of inflammatory arthritis, including rheumatoid arthritis, spondyloarthritis, and juvenile idiopathic arthritis. We'll examine how it is affected by medication, nutrition, and exercise. I'll end with practical conclusions and future direction for screening and intervention. Sarcopenia, traditionally considered age-related, is increasingly recognized as a consequence of chronic inflammatory diseases. In patients with rheumatoid arthritis, spondyloarthritis, and juvenile arthritis, sarcopenia is highly prevalent and leads to poor physical function, increased fatigue, and a more severe disease course. This makes early detection and management critical even in younger patients. Over the last 15 years, several working groups have developed diagnostic criteria for sarcopenia. EWGSOP1 is a European working group on sarcopenia in older people, worked out in 2010, focused on muscle mass and strength. While the next edition, worked out in 2019, shift emphasizes toward muscle strength as a primary marker. Other frameworks, Asian Working Group for Sarcopenia, Foundation for the National Institute of Health, Sarcopenia Definitions and Outcomes Consortium, differ in cutoffs, tools, and target populations. As a result, prevalence rates vary widely, especially in patients with inflammatory conditions. This slide illustrates how sarcopenia's definition changes prevalence rates across populations. WGSOP 2010 often produces high prevalence because it prioritizes mass, while FNIH shows lowest due to tricky cutoffs. AWGS shows high prevalence in Asian population due to regional metrics. These disparities not only complicate research, but also challenge clinical diagnosis, especially in rheumatology, where sarcopenia often remains undetected. Consistency in screening tools is urgently needed now. Patients with inflammatory arthritis face multiple overlapping risk factors for sarcopenia. These are systemic inflammation, corticosteroid use, malnutrition, reduced activity, and joint pain. These combine to accelerate muscle loss. Chronic inflammation disrupts anabolic pathways, promotes catabolic cytokine activity, resulting in both reduced muscle regeneration and increased degradation. Cytokines such as TNF-alpha, interleukin-6, and interleukin-1 beta activate destructive pathways in muscle tissue. TNF-alpha triggers NF-kappa B, which downregulates muscle differentiation factors and upregulates proteolytic enzymes. Interleukin-6 suppressed IGF-1, while interleukin-1 beta directly damages the muscle membrane. These mechanisms explain why systemic inflammation is so potentially drives sarcopenia in rheumatic disease. We used the EWGSOP2 criteria incorporating hand grip strength, muscle mass via DEXA, and gait speed. Recent nomogram-based tools for rheumatoid arthritis patients using BMI, disease duration, hemoglobin, and grip strength provide accessible ways to predict sarcopenia in clinical settings. This emphasizes the importance of simple, function-based diagnostics or imaging alone. Our cross-sectional study included 138 patients with inflammatory arthritis. Of these, 70 had GI, 51 spondyloarthritis, and 17 rheumatoid arthritis. Muscle mass was measured with DEXA, strength with hand grip dynamometry, and function with a 6-meter gait speed test. Sarcopenia was categorized into 3 stages: probable, confirmed, and severe. We observed sarcopenia in 47% of patients overall, with probable sarcopenia in 55% and severe sarcopenia in 22%. Rheumatoid arthritis had the highest prevalence, followed by juvenile idiopathic arthritis, and then spondyloarthritis. The findings indicate that sarcopenia affects a significant proportion of patients, even young adults, and warrants clinical attention. In rheumatoid arthritis, sarcopenia is influenced by chronic inflammation, high BMI, corticosteroid use, and low physical activity. Postmenopausal women are especially vulnerable. It's associated with slower gait speed, high HAQ score, and osteoporosis and greater joint damage, making it both a metabolic and mechanical problem. Our study shows that rheumatoid arthritis patients with sarcopenia had markedly lower muscle strength, higher disability score, and more inflammatory markers. The impact on physical function and quality of life was clear, highlighting the urgent need for screening and early rehabilitation. In axial spondyloarthritis, sarcopenia correlates with disease activity, reduced grip strength, and lower BMI, particularly in men. Over half of ankylosing spondylitis patients showed low muscle mass without yet having functional impairment or pre-sarcopenia. These individuals had higher BASDAI score, indicated that muscle loss progresses with inflammation. Sarcopenic spondyloarthritis patient in our study had lower muscle mass, reduced physical function, and elevated C-reactive protein. They also had worse functional scores and were more likely to have osteoporosis, especially males. This suggests the intersection between inflammation, mobility, and bone muscle health. Psoriatic arthritis shows a wide range in sarcopenia prevalence depending on diagnostic method. Only definitions overestimate prevalence. Functional assessment yield more accurate results. Sarcopenia in psoriatic arthritis had been associated with osteoporosis, particularly in postmenopausal women and lower BMI. Our study is the first to examine sarcopenia in adults with a history of juvenile idiopathic arthritis. Sarcopenia was common and linked to disease activity, prolonged glucocorticoid use, and low vitamin D. This group faces unique challenges due to disease onset during critical period of musculoskeletal growth. Sarcopenic GI patients showed higher ESR level, worse HAQ score, and reduced muscle strength. The duration of glucocorticoid exposure was a key predictor. These findings highlight a need for early lifestyle and nutritional interventions in pediatric rheumatology. Compared with non-sarcopenic patients, sarcopenic GI adults showed lower muscle mass and performance. Early onset chronic inflammation appears to have a long-term musculoskeletal consequences, emphasizing the importance of early intervention and regular monitoring. Sarcopenia in juvenile idiopathic arthritis and other inflammatory diseases is often silent, but has lasting impact. In younger patients, it impairs muscle development, mobility, and independence. Clinicians must not overlook the diagnosis. With early screening, dietary optimization, and movement therapies, we can reduce disability and preserve long-term function. Some DMARDs, disease-modifying drugs, especially interleukin-6 inhibitors, may preserve or restore muscle mass by reducing inflammation. JAK inhibitors also showed promise in preclinical models. However, results remain inconsistent across studies, and not all DMARDs have shown protective effects. For example, meta-analyses show mixed results. Some DMARDs increase lean mass, others rise subcutaneous fat. The effects of TNF-alpha inhibitors may vary by dose. Study heterogeneity and different diagnostic criteria also contribute to uncertainty. We need larger, standardized trials. Despite some promising results, particularly for interleukin-6 blockade, most data remain inconclusive. Further large-scale controlled studies are needed to clarify the true impact of DMARDs on sarcopenia in rheumatic disease population. Glucocorticoids use remain the major risk factor. Even low doses impair protein synthesis, promote fat gain, and accelerate bone loss. Sarcopenic obesity is emerging as a distinct condition in glucocorticoid-treated patients with poor physical outcomes. Glucocorticoids were more commonly used among sarcopenic patients in our study. Chikara data also show a direct dose response link between glucocorticoid exposure and sarcopenia, independent of disease activity. These findings call for careful glucocorticoid tapering and monitoring. Protein, especially lecithin-enriched stimulates muscle synthesis. Dairy protein, vitamin D, and white supplements improve lean mass. Omega-3 fatty acids have anti-inflammatory effects and may enhance strength. Creatine is also beneficial in rheumatoid arthritis. Combined intervention show the most promise. Supplements such as HMB and probiotics like lactobacillus support muscle maintenance. A combination of lysine, omega-3s, and probiotics improved mass and activity in all the adults, highlighting the translational value in rheumatology. Exercise remains the cornerstone of sarcopenia management. Resistance and aerobic training enhance muscle mass, function, and performance. Systematic reviews show clear benefits, especially when combined with nutrition. No adverse effects were reported even in rheumatoid arthritis. In rheumatoid arthritis, structured exercise programs improve lean mass, disease activity, and quality of life. A Tai Chi-based program with counseling showed remarkable results in postmenopausal women. For patients with joint pain, aquatic exercise offers low-impact benefits. In 16-week aquatic aerobic intervention, improved disease activity and function in women with rheumatoid arthritis, despite minimal gains in strength. This suggests that exercise can still be effective without high intensity, especially when joint preservation is concerned. So, in conclusion, sarcopenia is highly prevalent in inflammatory arthritis and contributes to disability, frailty, and reduced quality of life. It remains under-recognized and under-treated. Addressing sarcopenia must become a clinical priority alongside disease control. And future direction. Future efforts should focus on recognizing sarcopenia as a clinical diagnosis, integrating a screening tool into rheumatological practice, and developing multidisciplinary management pathways, including rheumatologists, physiotherapists, and dietitians. And finally, thank you for your attention, and I'll be happy to answer any question or continue the discussion. Please feel free to contact at my email. I welcome collaboration and feedback. Thank you.